Good evening. I'll try to finish very much quickly in order not to miss the match. Uh, Artificial intelligence precognition of breast cancer screening mammograms. The idea of the workshop is to see if the AI adds to our diagnosis or not. It's not a competition between each other or not the human versus the AI. Actually, the AI is to make the computer programs smart enough to imitate the human mind behavior. And fortunately, we have an AI could be used for the mammogram reader to increase the detection rate for breast cancer and reduce the workload issues. Mammograms at Bahia Foundation for Early Breast Cancer and Treatment has been recaptured since a year with the FDA-approved Lunit Inside MMG, where the AI algorithm provides us with the pixel level abnormality scores as a heat map in a form of a color hue that increase the intensity according to the probability of the breast cancer. Then we have the maximum pixel level abnormality scores, which gives us a numerical estimate about the confidence with suspicion of malignancy that ranges from less than 2% to 100% in case of suspicion of malignancy. And finally, we have the additional assessment of breast density categorized in 4 types with a scale from 1 to 10, which increases according to the density of the breast size. For example, this diagnostic mammogram, if we find it at the workflow, it's very tiring for us, especially if it gets us to at the end of the shift. I'm going to scan all these glandular tissue. They are overlapping tissues and there may be hidden a mass. I don't know where is the mass. And if I'm definite about the cancer, I would like to know if there are other minions or not. And this is very tiredous and very tedious. But with the AI, it's only 1 second. And I can get that I'm dealing with a large mass about in the upper outer quadrant of the left breast and with a scoring of 99% confidence that I'm dealing with the cancer. And actually it was invasive ductal carcinoma grade 3 and a true positive match. There are a lot of probabilities regarding the AI numerical value. The estimation of the 10%, it's definitely lung cancer. And we get down with these percentages is a subjective percentage according to the scoring. And finally, with the 100%, we are dealing with definitely cancer according to the AI algorithm. We need to know that this specification differs from one hospital to another according to the workflow. We'll go to the first case. This case, at the first glance, maybe the abnormality is not there, but when we go deep to the right breast upper outer quadrant, we could find these clusters of microcalcification. We are not pretty sure we are dealing with a benign or malignant calcification. Of course, it's suspicious, but maybe some fibrocystic changes give us this impression. The eye tells us all these areas are involved with the probably cancer with the 98%. On the ultrasound, they only give us this mass, which is about 2 centimeters with the calcification. It's not the extension like that we saw in the AI. Yes, we are definite about dealing with the cancer because we have the pathological lymph node. In the contrast-enhanced mammogram, the area of extension is more or less extended with heterogeneous pattern of contrast uptake. So we are going to go with the more suspicion of a cancer. So by the mammogram, we have a suspicious calcification in the upper outer quadrant of the right breast. For the AI, it's probably cancer with 98% scoring. The ultrasound, yes, it's 4 centimeters, but about the ultrasound, the estimation of the extent of the suspicion pathology is not like the mammogram or the AI. And with the contrast, there is more extensive involvement of the breast. It was an invasive ductal carcinoma grade 2, and the AI gave us the true positive, but the more privilege for the detection of the lesion is the extent of the pathology. We could see that the ultrasound gives us underestimation of the size, while the AI gives us the same extension almost to the contrast-enhanced mammogram. In case number 2, it's a little bit easy case. We could find abnormality in the left breast upper outer quadrant, a focal area of the indistinction. The eye gives us the scoring of average 91% is probably a cancer. And then we could detect it and target it in the ultrasound with the pathological lymph nodes. The contrast-enhanced mammogram, more confirmation about the malignancy of such a focus. And then going through the different modalities. Yes, it was invasive ductal carcinoma grade 2. Another true positive match with the AI. So we can say that the AI, in most of the cases, goes with our diagnosis with the mammogram and ultrasound. So why to add our AI to our diagnosis? Why to get AI in the workflow? It's actually when we diagnose malignancy, it exhausts the same diagnosis as we us. We doesn't need its confirmation. But when we go this case is 40 years with positive family history breast cancer. going through this mammogram with a very busy glandular tissue. It's almost all of it about white. Then we go deep inside, we can find this indirect sign of malignancy with focal tissue peaking. And this area here, it's having a more or less some grouped microcalcification. So according to the right breast, it's probably malignant. For the left breast, we have this scattered calcification of the fibrocystic changes. We are definite about it. But for the right breast, this area here with increased density and a little bit subtle distortion with the more grouped calcification. We want further evaluation of such area. The AI tells us it's possibly non-cancer. Don't give a damn about it. But I need the biopsy. Going to the ultrasound, I find this area with a scattered foci of benign-looking masses. It's most likely probably adenomatous masses. And I go to more demonstrative presentation with the MRI. Yes, it's multiple lumps adherent with each other, but due to being focality, it's a focal localization of these multiple adenomatous lesions. I may give it a little bit by RATS4 for the distribution of these probably benign-looking masses. When I take my biopsy, I found it was just intraductal papillomatosis, ductictasia, fibrocystic changes with no atypia. So if I considered AI, yes, AI give me a hint about why not to give the patient a chance for follow-up. It's not just that suspicious when you go out with the AI probability and going inside within this glandular tissue. If you'd like to stop me between the cases and ask me case by case, it's okay. If you have any questions about the cases, you could stop me in between the cases. Okay. Yes, if there is one case of debate, you need to stop me in between the cases. Okay, and questions up till now? Yes, do I? No, but I have this area. We have indirect signs of malignancy, this area of tissue peaking here. And the area here is of, if you compare both breasts, you missed it by yourself. you have to check this area. There is asymmetrical increased density, and the glandular tissue is clumped over each other with the calcification more grouped in this area. Okay, so you missed it. But the AI tells you it's okay, it's possibly non-cancer. But when you get such clumped calcification and an area of symmetry in a patient with positive family history, you should consider with close follow-up. And if you have a calcification, the close follow-up will be with a single view mammogram. Okay. Case number 4. For the left breast, we have the upper outer introductor lymph node. It's no big deal about it, but it's the condition about the right breast. Here in the lower inner quadrant, we have this area of distortion. Here, asymmetrical density and the subtle distortion. And here. Okay, when I go to the AI this time, it tells me also don't give a damn about this area. And it's only 34% suspicion of malignancy, although it looks very fishy on the mammogram. It's possibly non-cancer according to the artificial intelligence. So I go to further evaluation by other elements, the ultrasound for instance, and I found these ductal abnormal non-mass area with abnormal vascularity related to it. And the lymph nodes, some of them showing cortical thickening. We are not pretty sure it's in the dermal lymph node. More or less, yes, it looks reactionary, but I should give an action. Contrast-enhanced mammogram showed us this area showed heterogeneous non-mass contrast uptake. It's very fishy, and I should consider invisible lobar carcinoma or ductal carcinoma in situ. And then when I took the biopsy, I found it again intraductal papillomatosis, ductictasia, and unusual ductal hyperplasia. So this time also the AI gave us the good impression. It's true, negative, not other. In this way, there was this contrast between the different modalities, and all of them goes for the positive. The AI gives this the negative. So when to consider AI, this time all the modalities give me the positive, and actually on myself I would give it a positive impression. Yes, it looks very fishy, and I need a biopsy. So when I find the suspicious lesion on the mammogram or the contrast-enhanced mammogram or on the ultrasound, and the eye give me a low scoring, and there is inconclusive ultrasound findings, I have no definite findings about confirmation of the malignancy, I should consider close follow-up rather than biopsy, give the patient the chance for the follow-up. And when I found the progression, I step into the biopsy, not to go directly to the biopsy and give the patient hazards of the anxiety and unnecessary trauma. For the next case, when we compare the both breasts, we could find here in the upper outer quadrant of the right breast, these clustered microcalcification and the distortion being in the upper outer quadrant. The AI tells me it's definitely a cancer with 99% scoring. On the ultrasound, I couldn't find something. It's only ductal distortion. And the lymph nodes looks more or less benign. This time, the contrast-enhanced mammogram that enhances the suspicion inside me, because the distribution of the enhancement and the pattern of contrast uptake, it's a little bit suspicious. And so I have entered the biopsy option. So in the mammogram, it was by RET4, definitely with the calcifications and distortion. In the AI, it definitely cancer. In the ultrasound, it is inconclusive. And in contrast-enhanced mammogram, it's still, and it was invasive ductal carcinoma with ductal carcinoma inside. In next case, I compare again the both breasts. I divide them into thirds, the upper third, the middle third, and the lower third in order to take my abnormality. And when I go to the upper third in the right breast, I find these clustered, typical malignant looking microcalcification, and then high up here, these grouped calcification. It's amorphous calcification that I don't know where to go. It's for a little bit of time, we called it the indeterminate calcification. So I'm going to take the biopsy from all this area. It's very bizarring. And then I go to the other side, left breast. I show these areas of linear grouped calcification. And here also in the left deep central region, I don't know where to get my biopsy and if it's actually a pathology, an abnormality, or just the secretory changes that the patient was subjected to during her cyclic life. And then when I go to the AI, it tells me no, not to worry about the left side. All these calcification could be secretory, and it's about 10% suspicion. But for the right side, upper outer quadrant, it is the one to be of concern. It's 70%, possibly a cancer. Then when I be guided by the AI through the ultrasound, I could find not only this mass at the area of clustered microcalcification, also for the segmental calcification, amorphous calcification that was in the upper outer quadrant, these masses. So it was almost 4 masses. It's the index mass at the right breast 10 o'clock and the 3 minions that could be missed because one of them is, it's about 2 millimeter. This is the diagnosis of the different modalities, and it's multifocal invasive ductal carcinoma for the left side, the biopsy with fibrocystic changes, because I consider myself and I ignore the AI prediction that is only 10% suspicion of malignancy. Yes. Yes, and I took my biopsy. And it was fibrocystic changes. And that's what I was telling you the previous case. When I found suspicious feature on the mammogram and I get the AI to tell me that I'm dealing with something less than 40%, and I go to the ultrasound, I found no abnormality or inconclusive ultrasound, I give the patient the chance for follow-up. Okay? And more advantage of the AI this time is the targeting of the ultrasound. The AI demonstration of the color hue helped me to go through the different masses present in the upper outer quadrant and so give me a more precise extension about the disease. Next case, the breast is entirely fatty. I only find this area here and here. And I don't know if there is a patch, it's a glandular tissue because it have been stretched. Yes, it was here clumped. And here it was stretched. The AI tells me that it is here is 67%, but doesn't give her a color hue here in the CC view, although it's more demonstrated in the CC view. In the MLO view, it's not obvious. But yet we are in the range of the possibly cancer. On the ultrasound could be easily detected that it's in the retroalveolar region. It's surrounded with desmoplastic reaction, which is one of the most distinctive signs in the ultrasound that I'm dealing with cancer. So going through the different modalities, it's true positive by the AI, anti-invasive ductal carcinoma grade 2. But the point here, why AI have missed it in the CC and only counted in the MLO, and of course this affect the percentage of conception of being a cancer. It gives me only 67%. Why didn't it consider the CC, although it is more evident in the CC and the distortion is more evident in the CC, and if it considered the CC, it will have enhanced the scoring up to 90 or even 100%, even though, because the improper positioning, the AI considered that the nipple here, which is inward, and not in the proper positioning, and this one is comparable to it, so this is maybe the nipple as well. And so he skipped this area and considered it normal. So it's very important for the eye to give you the proper percentage, that you go according to the guidelines of imaging the mammogram. Don't use a C-arm, don't use a non-professionalized healthcare companies to image the mammogram and say, okay, it's a soft tissue organ, I could image it with any X-ray machine. No, it needs a special X-ray machine, which is the specialized for the mammogram, and with following the guidelines, authorized guidelines for imaging the mammogram, where to put your muscle, where to put your nipple, and where to stretch the breast, and how the operator is to be trained and professional in order to perform the examination. Otherwise, the AI will give you fallacies in the scoring. Next case, we are going to compare as well, and by examination, very careful, we could find here in the upper outer quadrant of the left breast, this area here of suspicion and distortion with some calcification related to it. The eye tells me again, don't worry. Yes, it looks suspicious on the mammogram, but the scoring is only 38%. It's possibly non-cancer. And I ignored the AI and jumped to the ultrasound. I found this mass. It's intraductal lesion. It's very fishy for me, macrolobulated outline. I won't left it, although I need to get a biopsy, especially with some of the axial lymph nodes, some of them a little bit with cortical thickening. When I jumped the contrast enhanced mammogram, it have even more raised my suspicion that I'm dealing with a carcinoma with the inhomogeneous pattern of contrast uptake and non-mass segmental enhancement. So I'm here by the contrast enhanced mammogram, definitely dealing with the cancer, and the eye this time, he missed it. And again, the intraductal papillomatosis. Okay, and the typical ductal hyperplasia. Okay, so now we are going to be minded that when we get a suspicious lesion on the mammogram and the ultrasound inconclusive, kindly consider that we have dealing with the item, the intraductal papillomatosis or the atypical ductal hyperplasia. It's maybe not cancer, and so not anxiety the patient. Give her the chance for the close follow-up. And when you find the progression, jump to the biopsy. That's the idea this time, the message this time, not just to give the chance for follow-up. And if you want the biopsy and you took the biopsy and it turned out to be benign intraductal papillomatosis, then when you go to the MDT with the discussions and with the negotiations and tells you go to the radiologist because the pathology is mismatching with the BI-RADS4, tell him, yes, it could be intraductal papillomatosis because the eye gave me a low scoring. Don't redo biopsy for 1 time, 2 times, 3 times, 5 times, and then anxiety the patient, exhaust her, and still it's a benign pathology. But the imaging gives this me BI-RADS4. It will not change. The shape will not change. It will remain suspicious. So don't exhaust your patient. When your biopsy turns out to be benign and the AI gives me a low scoring, yes, stick to it and be confident. The next case, it's the dense breast, okay? And I could find a mass here in the upper central quadrant of the left breast. It's partially circumscribed and partially obscured. And when I find such thing in the mammogram, I give it a BI-RADS3 and ask for another modality, which is the ultrasound. The eye, no marking, which means definitely non-cancer. And if I'm going to consider the eye scoring, I'll go with the adenoma. It's a benign lesion because it's partially circumscribed, partially obscured, and no need for the ultrasound. But when I go to the ultrasound, the lesion is microlobulated, and it's a little bit fishy, of course, although it takes the echo pattern of the breast fat and goes in plane with the breast, yet the macrolobulated outline, I should take a biopsy. Jumping to the contrast enhanced mammogram, the heterogeneous pattern of contrast uptake, and even it's also multifocal. I'm having here another focus. It's of higher density than the rest of the nodules in the pattern of the glandular pattern of the breast. So this time the mammogram with 3, because this was partially circumscribed, partially obscured, the AI tells me, no, it's definitely not cancer at all. And you could give it her annual follow-up. Then ultrasound and contrast enhanced mammogram with BRAF 4, and it was mucinous carcinoma grade 1. And then comes the idea, comes to my mind. Maybe some breast cancer types are hideous to AI. Maybe he's not that perfect and doesn't get all the types of cancer. Well, let me demonstrate some cases and see if the mucinous carcinoma is challenging to the AI or not. In this case, this is the mammogram to the right and the AI to the left. Going through these lesions, I'm having one at the right, which is very obvious, here, and another one here, which is benign looking totally, and another one marked by the AI, which is not obvious to me. So I go for the spot magnification and find calcifications, cluster calcification. Going to the biopsy for these masses, this one, it was mucinous carcinoma grade 1, another false negative. This one, it was mucinous carcinoma grade 2 and was marked by the IBIS 68%. And this is the calcification, is not part of the same carcinoma, it's a DCIS, but yet he picked up the mucinous carcinoma grade 2 and didn't pick up the mucinous carcinoma grade 1. Another case, here I'm having 3 masses almost here in the left breast, and he picked them all with the highest color hue, targeted with the red color, and 99% definite that we're dealing with a cancer. This was a multicentric mucinous carcinoma grade 3. So it's not about the cancer type, it's about the morphology of the cancer on the mammogram. When I get the fishy features and I get the speculations, I get the microlobulation, the cluster calcification in relation to the pathology or the abnormality in the mammogram, it gives me the scoring, which is the 99% and 100%. When the your pathology doesn't give you, so he could miss it. In this case, when I compare the 2 mammograms, it's little bit difficult to find a vertical histology at the first sight. I could say that the right breast, the abnormal one. But actually, when I go to the indirect signs of malignancy, I find tissue peaking in the left breast and obliteration of the subdermal fat with marked by the arrow. The AI tells me this time also, no, there is a cancer. There is nothing about this area. But actually, there was a lesion. It's about more than 2 centimeters with the distinctive feature of malignancy on the ultrasound, the desmoplastic reaction, and the lymph nodes. No one's missed it. It's the malignant pathological lymph nodes. Even though more confirmation by the contrast-enhanced mammogram with the speculation, homogeneous contrast uptake of the non-mass enhancement. So this time, I guess AI missed it this time, or goes with it, okay? And it's invasive lobular carcinoma grade 1. And again, the same question. Is AI, lobular carcinoma, challenging for the AI? Another case of demonstration. In this case, if you compare them, we could find in the right breast this area of speculation, and the AI picked it with 69%. It was invasive lobular carcinoma grade 2, and the true positive, although it is the lobular carcinoma. And in this case, we have a distinction of the carcinoma in the right breast, it's 94%, and we are pretty sure about it from the mammogram. We doesn't need the AI as well. So again, if you are going to go with the AI, it's invasive lobular carcinoma grade 3 this time. If you are going to go with the AI, yes, low scoring commonly goes with the non-cancer most of the time, except when the malignancy on the mammogram is small in size. This is giving me minus 20%. If it is homogeneous in texture, decreases more in the scoring. It's fat near or low density, and so in comparison with the glandular tissue, it's less dense than the glandular tissue. If it is in plane with the breast tissue, and if there is no distortion, if your pathology or your abnormality on the mammogram misses all these items, so he will give you no scoring. Okay, so this is not about a defect in the AI, it's about the morphology of the lesion itself. It didn't fulfill the criteria of malignancy. The next case, we can see here by comparison that we have here the areolar area showing thickening, a subtle thickening, and in relation there is an area of asymmetry with some fat lucency in the rim. I suspect the areas of solid distribution, but here we have lucences here of a fat. And so I may consider some ductal changes or ductal hyperplasia or ductectasia. Again, the AI gives me no marking, and with the fat lucences within this density, I could pass it by RAT3 more, at more intentions. On the ultrasound, it's inconclusive and may give the impression of periductal mastitis and Barrett 3, but actually on the ultrasound, the feature of solitary ductal orientation or even the pathology involving a solitary duct is by itself suspicious. So I get this item because sometimes when we do not find something about the ducts and the duct is just prominent, we get it by Barrett's 3. No, if the condition involving a sector, solitary duct or a few ducts, you should consider suspicious and give it by Barrett's 4. So the mammogram with 3 and AI, if I missed the idea of a solitary duct, it will be 3, and the AI gives me no markings, so I may go with the benign condition and tells the patient it's nothing to worry about. But actually it was ductal carcinoma in situ low grade. So please, when you find a negative AI scoring and the mammogram abnormality benign looking, but the patient is more than 45%, please biopsy the abnormality, okay? Or give the patient a close follow-up and monitor her, okay? Next case, if I compare the both breasts, I hardly find this area here is different on the other side, increased density, and there is a distortion as well. And when I go to the magnification, I find here there's coarse heterogeneous grouped calcification related to this area of increased density. The AI tells me it's 92%, and so I'll go with the cancer. Yes, this time the mammogram is suspicious, and the AI also giving me a high scoring. On the ultrasound, it's some adenomatous lesions, some adenomas, and one of them is benign looking and very fulfilling the features of benign adenoma. On the contrast enhanced mammogram, although I have a clustered foci, but it may goes with the adenomas or may not, because the clustered foci I may consider also ductal carcinoma in situ, so I give it a BI-RADS 4, probably malignant, because they are clustered enhancing foci in the upper outer quadrant of the left breast. Going through all of them, it was focal usual ductal hyperplasia with atypical epithelial cells on calcification. So again, yes, high scoring on the AI commonly goes with the malignancy in AI, except if I'm dealing with distortion of the benign lesion, this is plus 20%, heterogeneity of the abnormality, increased density than the glandular tissue, vertical tissue orientation, it's not in plane of the breast, it cuts the tissue vertically, and the large area of involvement. So I'll get high scoring, although my pathology is benign. This case is definitely normal. I have only 2 nodules. Here, this one, it's benign, and I go with adenomatous nodule, and this one also, okay? And give her the annual follow-up, right? Right what? Okay, and I go to the AI. No, it's not about the right. Both of them okay. You have this area of high hue. It's about 67%. It's probably a cancer, and I don't see the pathology. I don't see the abnormality. I go for the magnification. 1, 2, 3, 4. You see this calcification, it's very suspicious. The eye picked it at an instant. And also, just what I need is to follow the AI targeting this area. And thank you so much. I didn't miss the case, okay? It was a ductal carcinoma in situ papillary type. It's very aggressive and rare form, and it was a true positive for the AI. Next case, another fatty breast. And so the idea, so the AI didn't, not only very good in the dense breast, and could use it to help me in dense breast not to take a lot of time to pass through the glandular tissue overlapping over each other. Actually, in the fatty breast, it could help me to find lesion that is not, it's hideous for me. And for this breast, also, I could go here for the annual follow-up, and I find this area up here, it's 92%, it's definitely a cancer. And again, when I go there, it's only 35%. Why? Because the position of the breast is not appropriate, is not in the proper place. That's why it gives me a low score in the MLO, okay? On the ultrasound, I picked the carcinoma thanks to the AI. He guided me and targeted the area in the upper outer quadrant of the right breast, and the nodes also looks very better indeterminate, more towards suspicion. And it was invasive ductal carcinoma grade 2, 4 millimeter, when true positive early breast detection. The last case. First, when I do the comparison, I find these 2 areas. Then in the CC, yes, I'm having this area of distortion. It is very subtle. And here, tissue peaking. I don't know, the abnormality takes all this extent or only this focus of distortion. The eye tells me, yes, on the right side, you have your carcinoma. It's 91%. But on the left side, there's another lesion that I didn't see, and it was hideous for me. But it's possibly non-cancer. I go again for the right side. It's by RADS5. It is focus here. But on the left side, the ultrasound was defective. Going to the left side, that tells me there is a 50% suspicion of malignancy in the upper outer quadrant. Again, I do my magnification, and I find this cluster calcification of tubular pattern of orientation in the left breast. I'll go for the contrast enhanced mammogram, and the left side didn't show enhancement, only the right lesion, which is definitely cancer. On biopsy, the right one was invasive ductal carcinoma with lobular and signal differentiation, and the left one was atypical ductal hyperplasia. So thank you, AI. I get the calcification on the left side. No, wait. I get the calcification on the left side, and the mass on the right side was diagnosed. And I tell myself, why not to follow the patient when it comes to me in the next year with the AI as well? So when I followed the patient, it performed a conservative surgery on the right side, and the left side I still had the calcification that I biopsied a year ago. It was a typical ductal hyperplasia, and I want to follow up in order to know if there is progression of the condition or not. So I go to the mammogram, and a little bit dilamatous. It's the scarring having recurrence or residual mass or just a benign scarring. I need to do ultrasound. If it's the case coming to me in the screening mammogram, I need to know. So the mammogram by itself is not the modality of a choice specific. And what about the calcification? Well, here, this is the one I picked with the AI. And then this is the next year. It still looks suspicious. So, well, I will do the rebiopsy or give it a chance and follow up and take the risk that it turned up to be carcinoma from atypical ductal hyperplasia. The AI scanned it, and for the operative bed, low probability of being a cancer. And since the AI said on the operative bed that is distorted, that not in the plane, that of increased density, that I'm having a probability, so definitely I'm having no recurrence at the operative bed. Because here is not matching with the items we studied before. And about the calcification, this year it's 42%. How did calcification decrease? It's not a mass that shrinks in size, because the calcification, if it is due to secretory changes or hyperplasia, gets fats between them. They are pockets of fluid with calcification because the secretory changes, and by time gets fat, so they disperse. Unlike the calcification due to malignancy, it is within a soft tissue that goes in a track. It's blunt. There is no spaces between them. So when he found fat between these cluster calcification, it was previously clustered and clumped to each other, so much grouped, and then the next year they're fat between them and so much dispersed. He lowers the scoring, so this is perfect for following the calcification. There is no need to do biopsy every year for the patient, or when you compare it, I don't know, they look alike, they don't look alike, you have a numerical value, definitive numerical value that tells you, no, it's gets a lower scoring. And so they could be used not only for detection and diagnosis of a cancer, we could use it for follow-up of the uncomplicated operative bed. If I'm having scarring with no seriomas, hematomas, or fat necrosis, I get the probability that I'm not dealing with recurrence at the operative bed without need for ultrasound. And for the indeterminate calcification, I'm having the definite numerical value to tell me that I'm dealing with the benign calcification. The deep neural network artificial intelligence shows higher breast cancer detection compared to the best mammographic density module. So when I get the AI, I could follow the patient all through the case, even before the cancer. So this case in 2019, before the detection of the cancer was detected in 2020, and she performed the operation in 2021. Now we in 2019, 1 year earlier to its cancer detection. And I go to the ultrasound, I didn't find something, but I need to go to the AI, and the calcification was there but was overlooked because from the increased glandular tissue. And then I go to the AI, he marked the density, yes, lower signal, lower scoring, yet he marked the area that later on after a year developed the area of distortion and actual carcinoma. And if I saw the 34%, I may have considered the patient for a close follow-up. And in the other side for the calcification, it was in 2019, 58, in 2020, it was 50, and in 2021, it was 42. So I'm definitely dealing, even if I didn't use biopsy, with a benign calcification. Yes, do you want to have a question? Okay. So AI had prognition of the right breast cancer and detected also the left breast calcification that was overlooked in the previous year. What about this image? Yes. According to the scoring, it's not about definitely one modality. You should get a melange between the different facilities you had. But what's the idea about if you have these pictures, you don't want to go to the 4 views. You have only one image with the 4 views, with the scoring, with the color hue, and you could go through the different years of the patient and know the progression and regression of your disease. It's about, I go to the mammogram, it's suspicious. I go to the AI, it's not suspicious. And then I go to the ultrasound, there is no confirmation. So I may consider a close follow-up for the patient. I go to the mammogram, it's suspicious. I go to the AI, it's not suspicious. I go to the ultrasound, it's suspicious. So I'll go for the biopsy. Okay? I need confirmation for what I see on the mammogram. If not, I may give the patient the chance for follow-up. And also when I get the AI a high scoring and I get a mammogram benign looking, ultrasound benign looking, I get the patient for the close follow-up because the AI gives me a high percentage that is not confirmed by both modalities. But all of them is going with the low scoring. Okay, I give the patient the chance for the annual follow-up. Okay, it's about the algorithm and you have to think with it. Consider the AI as your colleague is giving you idea about the lesion, and you keep it in mind and see what, from your experience, I'm going to consider it or not. It's not a precise, it's not a limitation, it's not a clunch for you. Okay. There is no such thing about scoring or cutoff value for the AI in the authorized papers, except for the papers we have performed in Australian Hospital Kent University, supported with Bahia Foundation for Early Breast Cancer and Treatment. We get a 60% cutoff between the benign and malignant lesions. That AI itself as a product was initiated to detection of a cancer. And so there is no cutoff point. The company itself estimates that any percentage is a cancer, but the probability of high getting higher. All the lesions that's picked, even with the 20%, the 30%, the 50%, all of them are cancers with different degrees of suspicion of malignancy. But for me, when we performed the paper and the research in Australian Hospital and in Bahia, we try to consider that when we tell me that this lesion is black and I told you this white, so why not to get a discrimination? It's not black, so it's benign. When it's black, it's malignant. And I told you it's not black, so it's white, so it's benign. And this was the concept. That's why we performed the cutoff value. But this is only the concept in the papers performed in Egypt. But for the AI internationally to provoke this idea, all the idea is about that the AI is considered with the detection of the cancer only and not for the differentiation between the benign and malignant. But you need to consider it when you have a suspicion lesion, to consider it to enhance your suggestion of malignancy and give the chance the patient for the biopsy, or to down score your BI-RADS and give the patient the chance for follow-up. Okay. So AI assesses the radiologist in reading the mammograms and moreover improves the efficacy of screening breast cancer. If you have find these pictures, it's only 3 pictures for the patient, and I follow up through 3 years with a precise quantitative scoring and color hue. It's wonderful. I have a lot of information from only 3 images. AI finishes your sentence. When you write on the Google, I need whatsoever. If you don't have the appropriate keywords, you will not give you what you want to search. And this is good with the AI. If you know definitely where you are dealing and precise about the findings you have in the mammogram, not just going with the benign and malignant. No, I'm going with features, with morphology. I put them on side over each other, and so it will help me to get the proper solution. If I'm getting to the finish, I don't have the proper keywords, the AI may drag me down to the core. And that's why AI need to be the junior radiologist, and not like also all of the solutions consider him that it's the reader or the reference, reader number 2 or the reference. No, it needs to be the junior radiologist with the radiologist with him is expert one, and not to work with the junior. No, it works with the expert radiologist, not the junior radiologist. So what to take home points? First, that the AI target tiny carcinomas. We have to agree about this point. Easily and less time, effort, tissue diagnosis, and even the calcification are properly categorized. It also enhances the specificity for the determination between benign and malignant according to the quantitative value of the scoring, not only the targeting of the abnormality. If there is discordance between the mammogram findings and the AI abnormality, and it's not common in such case, they call the patient. but for the ultrasound. If you picked a low scoring abnormality and for the characterization and the recategorization of the highly scoring lesions. After the ultrasound, you will consider it's for biopsy or for close follow-up, okay? And then AI-aided mammogram, not only for the detection, not only for the diagnosis, it may also use as follow-up tools for the uncomplicated post-operative breast cancer that warrants ultrasound. No, most of the cases I may not need ultrasound. I'll give it the chance for follow-up by the AI scoring only, and the indeterminate calcification save the patient from the hazards of the repeated biopsies. Also, if it's supported with ultrasound, I could use it as alternative for the abbreviated MRI. I have the AI scoring with the ultrasound as a tool for the screening mammogram for the high-risk patient with dense breast. And if I got a low-scoring AI in dense breast, this doesn't mean that I'm dealing with a normal mammogram. No, please support your idea with the ultrasound, because sometimes you're going to find lesions by RAS2 or by 3 that is giving it a low scoring percentage. But for the fatty breast, okay, there were no need for the ultrasound as a radiologist, okay? Thank you.